in the UK, in Birmingham, there was a big tire factory, and they were trying to, they wanted to have a, the factory was demolished in 2000, and the machine, the testing machine, was taken to the Science Museum, which there's a Science Museum in London, but outside of London, there's a huge storage facility. And I became aware of this. So in 2003, I visited the Science Museum facility, and this is me. I had more hair then, so I'm holding a TSF, and this was the Goth testing rig. I mean, it's like really big. So that starts with, so that's Goth. And then in 1965, this man called Stewart presented a paper on using a flight to create a flight simulator, but nothing really happened. It was just one paper. There was nothing further was taken. But about the same time, in America, this man, Capel, working for the helicopter factory, wanted to create a helicopter flight simulator. So again, same 6 struts, and that is still used. So now if you see a modern flight simulator, they've all got the same 6 struts. We're going to use the same 6 struts, but instead of being like massive, it's going to be small. So that's where it started in the 60s, well, 50s. So circular frames have been around for a long time, and obviously it started with Ilizarov in 1951. And this man, Charles Taylor, he was using Ilizarov frames, but thought that he could take the principles from the Goff-Stewart platform and turn it into a way of controlling bone position. Obviously it started. So they'll do the same thing, but the difference is that with the Ilizarov, you have actual hinges which you've made, whereas with the TSF, the hinges are virtual hinges. They're not, but they're doing the same job. This is me again, more hair, doing a TSF course in Memphis with Taylor, and looking elderly note with a laptop, but nothing changes. But anyway, so that's where I started. So the evolution of the TSF, it's the rings, the struts, the software, and then the beacon have all been part of this change, this evolution. So the rings started with very straightforward rings, and then foot rings have been added, and colored rings are nice for children, I guess. And then obviously now the smart TSF rings, but they all have a similar overall pattern with the ring and the tabs for the strut mounting. The struts have also changed. It started with the standard struts, and you'll still see on the TSF, smart TSF. If you talk about the last step, you can still choose the standard struts. The difference with the standard struts and the fast fix is that the fast fix, you can rapidly change the length of the strut. These ones you couldn't change it. You had to turn. And then now obviously there is the fast fix strut, the smart FX struts is the third evolution. But it's important to understand that the standard struts still have a role. They'll go right down to 59 millimeters, whereas the smart struts, the Smart FX struts, just go down to 80. So occasionally, you need a really short strut, you have to go down to a standard strut. And on the software, which we'll see this afternoon, you can put those standard struts in if you're going to use them. Now, it's unusual to have to go really small, but there may be a situation where you might need to mix different struts of the same frame. So when in 1998, it was this thing, 3.5-inch disc, old school, so Smith and Nephew would hand it to me, put it into a laptop, and I'll show you the screen in a second. But now, obviously, the evolution is now on the internet, and it's much more calm. So this was the first. This is what you had to start with, just one screen. And actually, if you look, this is version 4. And on this version, you can save the patients on a database, not on the internet, just on your computer. But the first version, you couldn't even save it. So all you could do with this piece of paper was print it out. So it's the same information. You've got the deformity parameters, the mounting parameters, the strut settings, and then you would get the structure at risk here, and press on that one and get to a second page. But it wasn't saved you had to save it on your computer. It wasn't there was no database like we have now. But you'll also see that there are 2 operative modes. That was the only choice, was chronic or residual method, which again, still the chronic mode is on the Smart TSF, and it maybe has a role. So so these are various operative modes. The chronic and residual, which I'll talk about. The rings first, it's a little bit historical. It was a way of dealing with fractures, total residual, and then the Smart TSF, which is still the total residual. So with the chronic mode, you had to define the deformity before the surgery. You fill out all the details into the software. It would give you the strut lengths, and then you were applying a bent frame it would mirror the deformity. But you had to do the mounting parameters before you mounted it. So you had to be able to identify something on the X-ray to say, okay, that's where I'm going to put my ring. And then the software would just take it back to a neutral frame. So all the struts are the same length. So this was no good for fractures. It only worked for, a malunion. And it didn't work for fractures because you had to define the deformity before the surgery, and you had to apply the deformed frame to the deformed leg, and it would correct it back to a neutral frame. Everything was straight, same length. So this is an example, and we have this deformity. There's some translation and angular deformity, and so I've put the frame on. I've done so I put into the software what the deformity is, and I've told it I'm going to mount it in this position. And if you got the mounting wrong at the time of surgery, then your results would not be as predictable. So the problem with the chronic mode was that it was no good for fractures. If it was mobile, it wouldn't really work. You had to mount the frame intraoperatively according to your pre-op plan. So on the you had to say, okay, I'm going to put my reference ring where that, the level of the the scar or a fracture or a physis. And then once you couldn't change, you then had to follow the program, follow the prescription. You couldn't change direction. It was going wrong. Once the leg was straight, if there was any residual deformity, maybe you'd slightly overcorrected or undercorrected, then you would go back and you'd go the residual mode. So the residual mode starts with a neutral frame with some residual deformity, and then you would get back, then you would apply to run the program, a residual program, and you'd get hopefully back to a correctly aligned leg. So because it was no good for fractures, this was like a workaround, a hack to allow you to put a frame on with a fracture. So this is called rings first, and you apply a ring to each segment. So this is a fracture, and we've got one ring on this segment, one ring on that segment. You then work out what's called the neutral frame height. So you measure the distance from the fracture to from the ring to this fracture, this ring to that fracture. And you'd measure that, and that would give you a distance to say a neutral frame height is 140. So when the fracture is aligned, the rings will be 140 millimeters apart. You then had to go to this conversion table, and first of all, you had to say, this is a 155, 155. If you had a 180, 155 frame, there'd be a completely separate table. So you'd say, okay, my neutral frame height is 140, and that equals a strut length, because the struts, you're running obliquely, so it's not the same number. So now you say, okay, my neutral strut length is 131. So if I put everything to 131, then I should have reduced the fraction. So it was a lot of, like I said, it was a hack to get around the fact that we didn't have the total residual mode. The problems with it was you couldn't specify the structure at risk, and you had to have the bone within the ring in a matched position, because otherwise you'd have some translation. So it was better than anything else, but it wasn't perfect. Then it changed when it went to a web-based. Now we have the total residual mode. And obviously this is much more powerful, and this is what I would use now. So again, we've seen this is the first web-based program, which I'm sure people seen this. It's not available now. It's all Smart FX. This disappeared about maybe a year ago, 9 months, something like that. And I had a lot of cases on it of all. But anyway, I guess. So now it's obviously the Smart TSF, which is what we're going to be working with. And there's a lot of similarities between the old system and this one. But there's some very good and important advantages. The beacon is, well, we'll see that this afternoon. That's another evolution, and is very useful, especially for working out the mounting parameters and also the counting for any magnification. So it's been a 26-year evolution for me, from 1998 to 2024, and the changes have been there's been an evolution in the hardware, the software. It started with a disk. Everyone remember disks? Lose it, obviously. And then the spatialframe.com, which is gone. Now it's Smart TSF. And then the operative mode has changed. So the chronic, it's still on the Smart TSF. You can still choose that chronic mode. And then the residual, if there was any small deformity left over. The rings first is history. That was just a hack to treat fractures. And then the total residual, which is obviously much more powerful. So thank you very much, and that's where I work. Yes. Yeah.
chart for the strut.
Yes.
It's based on fixed angle of the strut.
Yeah.
When you draw within 140, the strut length must be 131.
Yes.
It's based on a fixed angle.
Yes. So all the struts would be the set. You'd set all 6 struts to the same, to 131, and with the struts at 131, the distance between the ring above the ring below would be 140. I calculated, and that would get a fraction of the ring. It wouldn't do anything to really change if you set the ring orthogonal to each segment, if you then pull it so that the rings are parallel, the theory was that the bone fixed to the ring would be reduced and out to length. So you would correct the length. So the only how it would correct, say, some angulation is because if you each ring is fixed orthogonal to this segment, both, and then you pull it, make the rings parallel. Fracture, the theory was that the fracture should straighten out, but if you've got it fixed, the top ring, say the bone is in the middle of the ring, and the bottom ring, if you have it fixed in this. So you have to fix the bone in the same place above and below, because if this was the say the reference ring and the distal ring, you fixed the bone there, then when you straightened it out, there would be translation error. That's the problem with it. So you had to get it as best you could fixed in the same within in the middle of the same part, whether it's the middle of the ring or one part of the ring, which is like tibia. Tibia is usually at the front of the ring. So it wasn't perfect. I mean, it wasn't, but it was a way of getting around the fact that we didn't have a total residual mode. The other way which you could do it is you put the frame on, you just pull it, reduce it to get the struts all the same length, the neutral frame, and then you say, okay, I have some residual deformity, then you do a residual program. But I found the rings first actually a little more convenient.
Do they have a limitation with regard to severe deformities? So you'd have some struts at maximum length and some other struts at very minimum length, because the deformity is so severe in the bone. Have you had this problem using this range?
So usually there's enough. So the answer is no, I haven't, but because there's a very big range of struts. I certainly had frames where I've gone, I've had to strut change from short to medium to long, particularly Blounds, when there's a lot of the struts on the inside here very short, and as you're correcting it, you have to do many, you're changing the struts to go up.
Maxed out.
Yeah. Then you got to the next one.
So we have different sizes regarding that.
Yeah. So there's a huge, very big range of size, and in fact. Sorry, I'm going to go back one. Here we go. So the range of sizes could start. The shortest is the standard 59, and the longest. So you have a range from 59 to 311, but the different struts have. Okay, these two are the same, but they have a. So you have lots of options, and all of them. And that's the extra short panel. And so you can really have a huge range of struts.
Okay,
Thank you.
thank you, Mr. Gali, for this very nice history. I was not aware really about this history very long time ago. So please ask me questions. It is a workshop, it is not lectures, it is, so we need questions, we need discussions. So I will be showing you the structure of the TSF now. Maybe one of you have used this before or have seen that before in any patient in your clinic. So what we are going to is, no, nothing in the screen. So essentially, the TSF is the components we can talk about is like only 2 rings and 6 studs. So always proximal ring, distal ring. There is terminology we use also the reference ring. We have to determine which ring is the reference ring. So there are 2 rings, and one of them should be the reference, which means that the deformity, it is invariant in relation to the reference. It is this one. But if we consider that one, the distal one, is the reference, you should change the deformity. That is the terminology. So the first thing that we have to determine which ring is the reference ring. Any frame should have a reference ring. And also 6 studs, they are always numbered from the master tab. So the ring, if I can show you now a ring. So the ring, this is the TSF ring, which is totally different from the Elizabeth ring. How it is different? The first thing that it is, there is tabs. These are the prominent parts of the ring that's called tabs. And there is one with 7 holes tab. This is the master tab. So every ring has a master tab on it. And also there are other prominences, we call other tabs for the struts. So if you hold anything, if there is tabs, this is a TSF. If there is no tabs, this is a Elizabeth. And also another difference may be the Elizabeth rings that is maybe thinner. TSF rings are larger, so sometimes it's difficult to change between the struts with Elizabeth rings or TSF rings. So what I need you to remember that this is the ring, and it has tabs, a master tab, which means a 7-hole tab, other tabs, and it has a different sizes. So this is 180 millimeter. So it is big. There is a smaller rings depending on the size of the leg. So sometimes you use 155 or 180, depending on your leg size or the patient size. So it has different sizes and also different shapes. So you have a full ring and 2/3 ring. So the ring can be a full or can be 2/3. Sometimes we put the 2/3 around the knee to allow flexion, more range of motion for the patient. And this is one of it is the same as we have here. So this is the 2/3 ring. It is also has a master tab and 2 tabs behind. So master tab is a very essential part of any ring. If we can remember the ring, we have to identify, is it a reference ring or not? And then we go to the struts. So the struts are the connections between the 2 rings. And it is always numbered in a very fixed way. It is always 6, cannot be 5, cannot be 7, it's always 6. Starting from the master tab, this is the master tab. If you put it on the leg, and that is the tibia, if you can bring the concept this. So this is strut number 1, and this is strut number 2. So you counter clockwise. Yes, if you put it previously before the smart TSF, we always prefer to put the master tab in correspondence with the tibial tuberosity and the proximal ring parallel to the joint. So you put it like this. You see, it is like parallel to the joint, and the master tab master tab correspond to the tibial tuberosity. This is how the TSF will be applied onto the tibia. How we count or they arrange the struts, always start with a master tab, then this is strut number 1, number 2, 3, 4, 5, and 6. And it is color coded, which means this is the first one, it is red, then change to, I think, orange, then to yellow, then to, and about to the 6, it is violet. It's the rainbow color. And you have to mark them for the patient because we'll see now in a minute how we will make the adjustments after to do the correction. So it is like 2 rings, 6 struts. The struts, Mr. Barry talked about different types. It is we have nowadays we have 3 types of struts: standard and fast fix and the smart ones. In Jordan, we haven't any smart struts here now. They are coming. Until now, we don't have them. What we have now is only the standard and the smart, the fast fix. What we mean by the smart fix, it is like you see how it is going up and down fast. Because we have a knob here, you can just slide it up and then it will start there. So yes, it's very easy. If you work on the standard, it's difficult to, you have to go manual over the link. But the fast fix is that we just drop that. This is what we call fast fix. And the strut itself, it has a connection with the ring. So proximal connection and distal connection. And it is a telescoping. It is telescoping strut. On one side, there is a white colored numbers here. So it is the length of the strut. And there is a cursor in the middle. And it won't where exactly what is the length of the strut. So it can change different length from to different on the size. We have small struts, medium struts, large struts. So every strut has a range of lengths. We can apply them. Thank you for the colors. So we have 6 struts. Usually today we will work only with a fast fix, but we will not keep that. We have to look it back to make it stable, and then we can do the lengths. So this is the color. Again, we have to know. I think you'll make it from the, because 6 is in the violet is there. No, it's بنكتبهم.
Just to add exactly what you said, the numbering sequence is always the same. It doesn't matter if it's
And you can always please comment.
Okay.
There's a discussion.
the numbers the same. It's the same with the left leg, right leg, the leg or an arm, distal referencing, proximal referencing, all of it is the same way around. Because if you get it the wrong way around, it'll go in the wrong direction. And I had that problem. Someone had a frame put on at another hospital. This was when I was doing adult trauma. And they came to my clinic and he had the prescription, he brought it with him. And the fracture was going in the wrong direction. And I was sort of scratching my head, what's the problem? Maybe they mixed up left and right. Then I realized they put the numbers on the wrong way. And so it was a reverse. So it went the other way around. And then it was like, okay, with a small adjustment, we're going to take these numbers out and put them in, and we're going to run the program again. But that's really important. And the master tab, as you said, the software assumes it's at the front. And if for some reason you put the master tab inwards or outwards, maybe on purpose or maybe by accident, you can as long as you tell the software that you've rotated the frame inwards or outwards, then that's fine. But it makes an assumption master tab is strut 1, strut 2, anterior.
Yes, exactly. Thank you. So the master tab is because this device is connected to the computer will not understand where the frame is. You are telling them where is the master tab. So you are telling them, for example, it is in the front of the TV, exactly in the TV, exactly in the mechanical axis. This is what we are telling the computer when we enter the data. and get one. So, okay. And the last thing about this frame is the beacon. This is the new thing about the smart TSF. So maybe 1 year only, when we started less than a year ago, started to use the smart TSF. Before the smart TSF, we were using the regular TSF, which is different. They are not using this, the beacon. What is the beacon? Is this small device here? So this will tell the X-ray what is the parameters and the calibration, and exactly what is the relation of the bone and to the master tab and everything. So this beacon has small dots. Here it is 16 dots. You will see them in X-ray. They are radio opaque dots. There are 16, so 4 limbs of the beacon. So what we do usually, after the surgery, the day after the surgery, we take the patient to X-ray, myself, patient, and we take a proper X-ray for the device, for the frame, on the limb. So this should appear on the X-ray at least 12 out of 16 dots. So this part has 16 dots. We need at least to see 12 of them to make the X-ray excellent for interpretation. Exactly. So before this, what we used to do, maybe Mr. I will agree to me about that we need orthogonal review about the reference frame. Is that right? Before. So previously, before the smart, we need a orthogonal review. We have take a very precise image.
Yeah. You had to tell X-ray, which is I want the X-ray centered on the reference ring, whether it's proximal or distal, of both AP view and lateral view, and you wanted to see it like like a single line. You didn't want to, and it was sometimes X-ray. It took to go back, and usually they eventually they got to learn how to get the correct X-rays. It took a bit of time, and then the same with the beacon. It's now much more flexibility to get the X-rays. It doesn't have to be so close. It has to be fairly close, but it doesn't need to be so close. But now they have to learn to get the beacon on the X-ray.
Yes.
Because before they used to, they would just have the frame, and then the beacon would get lost off the side. Now we're saying, got to get the beacon on the X-ray.
And still we are repeating the X-ray. So we need at least sometimes 5, 6 times to get the right image, because the system will not accept the image if it is not right. So it will tell you that I cannot analyze. You need to make a new image with the beacon there, and at least it will do. So still it is tricky to get an X-ray with the whole thing, and in addition to the beacon, the most important part, to make the X-ray to be analyzed by the system. So this is the smart TSF. It is like the traditional TSF, but it is connected with beacon, 2 rings, proximal ring, distal ring. One of them is reference ring, master tab. This is a very important terminology. And the struts, there are 6. We are using a fast X, and it's always numbered anti-clockwise from the patient side or from the surgeon side. The last thing I will show you is the programming or the prescription. So after we apply this hardware on the patient leg and did the X-ray, okay, then we will make the and we will make our prescription. You can just show us this. I don't know if all of you have seen that or not. This is the prescription we give to the family or to the patient. So when we analyze the deformity, and we will do that programming, we will end up with 2 papers or 3 papers. And yes, if you just make it large. So this is the prescription. After we do the programming, as you will do this afternoon, we will end up with this page. It is containing the patient data first, and then they will tell us how it is like. For example, in this case, we are doing lengthening for the tibia. So for down, or this is what's for shortening. So minimize, please. Minimize the image. No, I mean the PDF file. Okay, perfect. So this paper will be with the patient and it contains 7 columns. On the left side there, it is the day and the date. So every day there is a change in the strut, either goes up or goes down. And every strut has a number on it. You see, for example, on day 0, which is the current situation, now it is when the patient living data. So it is on day 0, 205. On the following day, it is 203, which means they are going down by 2 millimeters. This is changing all the time. And if you go to the strut number 2, no, strut number 3, 4, 5, and 6. And here you can see a change in color. What does this mean? This means that you need to change the size of the strut, maybe with someone shorter. So it is like maybe medium. Now they will tell us in the last page what is the size of the strut change. The strut change can be done in the clinic. It's quite easy to change the strut. You don't need to go to theater to change the strut. We change that in the clinic. But when is that is exactly is shown in the table. You have a range of days. It's not only one day. So they gives you like at least 2, 3 days, maybe 5 days. So they are telling us strut change from strut number 5. The first day will be, for example, 18th of September. The last day, you have to get the strut change by 22nd of September from the fast fix range, the fast fix medium. So you are telling the patient that at these days, I have to see you, I have to make the strut changes. This is the prescription. You will get every one of you after in the afternoon session. He will print one. Then after the mounting, so we have the mounting, we call it the mounting TSF, meaning that we are putting the TSF on, and then we are doing the programming to make that schedule for the connection. Okay. I hope that this is all the components that I have maybe to tell you, but I'm ready for any question.
The idea, the beacon. So why did they invent the beacon? So we could, it's the same thing. We need to manipulate the rate to get the 12 volts for them in the X-ray.
Yes.
I understand. So I still, so why did they invent it?
So you will see how it is now after the smart TSF to
It's
upload.
easier, just.
I don't know this upload the images because previously we were working manually to analyze the deformity. But now you will not do that. It is like only upload the X-rays and it will tell you everything, just like you are doing small manipulations. Yeah.
So can I still use it?
Definitely, yes.
Yeah.
Yes. You can do it manually, but definitely it is better than previously. It takes a long time before you do the manual readings and everything to do the deformity planning. But now with the beacon, it will help you with the X-ray. Because in the new system, we are uploading X-rays. You remember before, we are not uploading any X-rays. It's just only taking only one X-ray and you measure the master tab in the relation to the core or to the origin. Because to tell it to the device.
So I don't have to measure the core and the still
They will calculate it for you now. Automatically, they will give, for example, the master tab is far away 22 millimeter from the anterior plane, from the sagittal plane, from the axial plane. This is the benefit of the beacon. So it's managed for the X-ray and for the device.
I need, for example, tibia, an alignment view for the tibia, a filter forward. I need to be parallel to the reference range so that the proximal or the distal range. I need to be parallel to the, for example, proximal range. And then I need to add a scalar ball. Scalar ball is something because, imaging doesn't really give you the exact measurement. It needs calibration. So you put a scalar ball. This, the actual.
This is with the old system before this one.
With
Yes.
the old system. you know the actual diameter. كاسينو أقرب ما يكون, and then you take the X-ray, you measure it on X-ray, and then you make the changes. Exactly, the magnification. Because these radiology instruments, they need calibration, but you do it now. So as much as I also said, we at the end we ended up going and doing that because you have this brilliant radiologist, which I'm sure
No way.
yeah,
I do it by myself in the surgeon. Hey,
exactly.
so I do it. Yeah. So I use a 6 millimeter thing as reference. I know it's 6 millimeter. It's a very little them.
It's a lot, making it more accurate, easier, user friendly.
So I think we use the coin as Razi said, I don't know, it's about what you used for calibration before. Maybe the man is using the strut or the rod 6 millimeters,
Which is
fixed.
yeah.
I don't know what tricks we can use to make the calibration.
So I point out about the calibration. I'd rather use like the 6 millimeter half in the olive wire. The olive wire is 4.34 millimeters, but whatever you calibrate, it has to be on the bone. You can't calibrate on the ring because it's for a bit of a hinge that's too far away. And whatever it is you calibrate, it's got to be on the bone. So the 6 millimeter, you know the half is 6 millimeters. I think my only other comment about the beacon is that it can't go any old place. It has to go in fixed positions on the ring. You tell the software where it is, and it has to go on the reference ring. You see, and it has to go either above or below. So you can't put it inside the ring.
So there is X mark where you can put the beacon. It is usually posterior medial or posterior lateral, but this is not new rings. There is no X there.
Beacon has to go here, here, or actually front. Fixed positions, and it has to go up. But if we were doing distal referencing, the beacon would be here, but it would be pointing down. What you can't do is have it sitting.
So it has a special place to put
Yes,
beacon.
they mark with
1, 2,
X.
3, 5.
They mark with X. You can put that, but these are not the smart rings.
So in the surgery, sorry.
I can.
So during the surgery, you'd fix the beacon mount onto the ring, and then that would stay on the patient.
The connectors, yes.
Connector. Quite expensive.
1,000 GD.
You have that. We have it in the clinic, but it doesn't, you have it somewhere, and they come for their X-ray, and you fix the beacon on, and it's only for that first X-ray. When you're getting X-rays up the week, I do an X-ray every week as the leg is correcting, but I don't need the beacon every week. I only need the beacon for the very first X-ray when I'm generating my parameters. When they come back to the clinic after 1 week, or as you go through the program, you don't need the beacon then because you've already done all the calculations. So the mount, this bit stays on the patient, and this bit on and off. For the X-ray, then you take it off. They don't go home with this.
And even DR is not allowing us to take even this bit. He take it. So it is only for the first image after the post in the post. It's not even the follow-up. Any questions?
But just
This adjustment, if you go back, yes, definitely yes. We call it the frame talk. We are talking to our patients before the surgery that this is the device we will apply on your leg or on your thigh, but after the surgery, we will print that in color. So the colors are very important. So it should be colored copy, and we give that to the patient and we sit with them and teach them how they will change the start and how they will follow the program, the adjustments.
So, we have to re-explain the patient. And this is not automated, and you have to update the software, the new X-ray. And if the patient messed up from work.
Okay.
The next X-ray, let's follow up clinic, you have to X-ray the patient. How to check.
To check the start date. This is very important. In every visit, yes, in every visit, you have to make check to check that he's going right. Because we are today, my clinic is Wednesday, so every Wednesday I see my patients when they are on the correction time. So every week we see them and I check what we are on Wednesday. Are your measurements right? So start number 6, for example, should measure 2 or 2. Then I go there and check. If there is something wrong, we can correct that. But we should have all patients that are very smart. They really do what exactly they're being informed of.
Somehow can be automated, this some wireless signals of chat, then the software just give the signal,
There is a mobile application now, can give to the patient and they can give him a light adjustment. No, there is no alarms, no.
Do we need to get X-ray each visit?
No.
The patient comes to
The
the.
answer is maybe no. This is it's not related to the prescription. So the prescription, what we do usually, that we give them a prescription for 2 to 3 weeks, and we think that this is will make the deformity for full correction. But at the end, on the last visit, you see that there is a residual deformity. So we do the X-ray and we make our alignment, the mechanical axis, AB lateral, make sure that we got the correction. If you did not achieve your correction, then you create another program, another prescription. It's very easy. So you in the Cure clinic sometimes take maybe less than 10 minutes to create a new program. For example, I have a residual 10 degrees valgus. That's it. You can just enter that there is a residual of 10 degrees valgus, and you make a new program for 5 days, 7 days, and give it again to the patient. So the beautiful thing with the TSF is that you can manipulate with the software. While in Elizabeth, you need to take the patient to the theater. If there is a residual, if you correct a leg with a valgus deformity, 40 degrees with Elizabeth, and then you reach your maximum to residual 10 degrees. What you do, you have to go to theater to change the struts and the hinge, or the rods and the hinge, and then you start a new program. But with TSF, really you don't need to go to theater again. You can do further corrections in the clinic. And this is why I prefer the use of the TSF. I know it's very, very expensive in comparison to Elizabeth, but if you do two surgeries with Elizabeth, this will make the cost the same. So maybe in Jordan, the cost of this device may be like 5,000 GP. Maybe Elizabeth is something between 1,000, 2,000, maybe less. But if you do 2 surgeries for the patient, definitely the cost will be the same. So if you are very, very experienced in Elizabeth, it is much cheaper. But if you are struggling with Elizabeth, this will be much cheaper for the patient. Mr. Barley is, yeah, next. I don't know if you can every visit.
I do usually. I certainly want to if it's going okay, and I might, but I'm always very. So the answer is I probably do too many X-rays. I'm too anxious. So I will X-ray most visits. Even if it's like over, I don't know, 4 weeks, I'll do 1 X-ray 1 week, and if it's going okay, then I'll come back, maybe send them away for a couple of weeks. It depends on the patient. Depends whether they. So I'm only treating children and obviously the families. I encourage the children to do their adjustments, be part of it, be part of the process. But I do X-ray most visits, but I probably do too many X-rays.
How often do the patient visit you?
Every week.
Every week. So
That's
you do
it, every
X-ray
week.
Every week. X-ray?
Yeah, until they finish their corrections, and then when they've got through the program, then I would sort of say I'll see them usually every 4 weeks. So I see them every week, and watch it like a hawk, you know, and I'm really on it because things can go wrong. And like I said, I've made mistakes. I've got, saw this patient, the one I mentioned, they put the rooms the wrong way, the numbers the wrong way around. And if I hadn't seen him every, you know, I would have not seen that. Or early on, before that first, you know, there's the software that actually I put up. Now you have to choose left or right. In that original software, it always went to right, and it was a left leg, and I didn't spot that. I wasn't thinking. It was one of the first cases that I did, and they came back and it was going in the wrong direction. I was trying to work out what I'd done wrong, and I suddenly realized that the software defaulted to left, to right. Now you have to choose left or right. The old software, it always went to right, and it was a left leg, and it was going in the wrong direction. Because anyway, so that's why I have, you know, I'm always really worried that it's going to go wrong. So it does. I mean, you know, usually it's fine. I mean, almost always, but I always check their numbers to make sure they're on the correct path. Usually it's pretty close. It may be 1 out. And I just tell them, okay, we'll just put it back to where it should be. Catch up. Or if you're too far ahead, slow down.
And also advise to see them for wound check, for the
Yeah.
chart. So in the first weeks, we need to follow them weekly, but then after correction, after finish, maybe every 3 or 4 weeks.
Yeah. They finished it.
They can make it.
I've done all the corrections. I don't need to do anything else. Then they go away for like 4 weeks, usually like 4 to 6 weeks.
For physiotherapy.
Okay. Any questions? There is a lot. Yeah, there is this one. This is really question tax. So first it's fast fix and how to control the fast fix. We stop this. It's like around here, but this is this stopper. So if you go down, always when we finish the correction, we take that bit down to look at the strand. Now, because I've seen some patients that even during sleep, there is some, because this can turn very easily. But if you look that bit down to it, it will not come. So this is very important question, I think. This is very important question because, and even some patients I told them after every correction, please look at it because it changed. It really changed even previously.
And just to comment on the strut changes, so with the 6 struts in, it's a very rigid system. If we want to change the strut in the clinic, we take that strut out, and suddenly it's like all over the place. So what you have to do before, yeah.
So 6 should be always 6. You can put a 7 and then change the strut. Never change the strut, just make it out and put it. It will lose everything.
Yeah. So let's say I wanted to change this strut. In theory, so I'm going to put in another strut anywhere. But I usually put it close to where I'm changing it. So if I was changing this one, I'd probably put it up here. You could put it on this side, but I tend to keep it somewhere near to where I'm putting the strut. So you put 7 struts in, take this one out, put your new strut in, then you have to remember, take the first one out. But yeah, it's really important. You can see how it becomes a totally unstable frame with only 5 struts in it. There has to be 6 struts at all times.
In the past, when they made struts, they didn't have this locking system, and it used to collapse.
I mean, there are lots. I use just an extra strut. I think there are, particularly on Smart Effects, they have some extra. There's an extra thing which goes across there, which I haven't really used. I just use another strut.
It is very, very risky to change the strut without 7 strut. Even if I remember one, I changed the strut without doing the locking. I forgot just to look it, and then it started, and the patient, it was a child, it started to cry, the pain, because The deformity has changed a lot in a sudden. So you have to put 7 strut and all locked because the device will collapse immediately if you just remove 1 strut.
And then the only other thing to say about the struts is it doesn't matter which, so here, it doesn't matter which way up you have it. So if it's the patient, they're looking, so in this position, all the numbers are upside down. Because it's one fit, but if it was the patient doing it, they're looking down and they want to see the numbers. I flip the struts round. But if it's the parents, the children, the parents doing it, then I had it this way up. So it doesn't matter which way up the struts. I mean, you can alter it, doesn't make it, you know, so that doesn't make any difference. But it's for the views of the patient. I don't know if you do it.
We do this way.
Do it this way.
Because the parents are.
If the parents are doing it, then that's fine. But if you know, an older child, they want to do it, then you can turn the struts the other way up. Make it easier to read from my perspective.
But all should be in the same direction for ease, just like.
Yeah. I mean, yeah, I'm never going to be alternating it. They'll all be one way.
One way. Any further questions? Master, please.
I always refer to that, it's for the software, yeah.
Yes.
So take the computer is the last software. But can I change the last software? Can I take the software, this is the last software? Or not? I'm using another tab for it. Because I see that tabs have slots, other tabs have no slots. So what's the, make a big difference to say to the computer, this is the last software, or I can choose just a tab and make it a lot.
No, you've got to have, master tab always has strut 1, strut 2.
Is related to the struts. The master is connected to strut 1, 2.
Can the computer start to change the last one? I choose which is the tab and say this is the master tab. And we'll start saying this is last part 1, start 2, start 3, start 4.
Any tab can be a master tab. Yes.
Okay, I can.
In the new system of the smart TSF, even you are not strict to choose the tabs, so you can change it. There is a settings on it. We will see after noon. But in the smart TSF, you can even change the size of the strut. It is always, we are classical teaching that this is number 1, this is number 2. But in smart TSF, you can change it. But the master tab is only related to strut number 1, strut number 2. It is the origin. It is like the device is telling you are telling the computer this is the proximal link is there and the master tab is there. Is that right?
Yeah,
Yeah.
you have to. And so the only difference, and again, it assumes that it's anterior. Now, the beacon will tell you if it's to be rotated inwards, or you can, or the software, you can say, I've internally rotated this, my reference ring, either because on purpose, or I've made an error, during the surgery, I put it a little bit round, not quite where I want it to be. But no, the master tab is always 1 and 2. And if you try and say that was 1 and 2, that means if you just rotated the frame line like that, still those 2 tabs, and you'll see that the 2/3 rings just have 3 tabs, and then the full rings have 6. But the small, except the small ring, like I think 130, rings go down to 3 tabs. So again, but you'll always, even if there's 6 tabs, you're still, there's an empty tab here, here, and here. But the 2/3 rings always just have 3 tabs.
And why there is the more holes than the master tab?
For the half pins. If you need to put a half pin or KYL or for, because this is the connection. This is how you will connect the ring to the tibia. You need slots to put the KYL or more options. So a lot of options. It's like it is always the same. They have the holes, but I mean, in the master tab, you can put the KYL here until you half pin. So the other holes is.
That's true. And also, with the smart, so the standard TSF, you always have to have the 2 struts in that position. You'll see on the smart TSF, if for some reason you have to, if you for some reason you fix this strut maybe back here.
It's okay in the smart, but not in the previous.
Yeah, exactly.
Exactly.
You could fix it
In another.
in another hole. But there's only limited
Options.
options, and you'll see there's like, so it's slightly, gives you a little bit more flexibility, but and it's the same for the other ones, and so you have a little bit of flexibility about exactly where you fix it with the smart, not with the previous one. You had to fix it here and here. And so they've given you a little bit more options for, yes, more wire fixation or hard pin placement, but also if there's some reason you have to put, you have a few more options about where you fix it, the strut 1 and 2. But you have to tell them.
It's two-sided for skilling. You have to add another ring, you get two machines.
Yeah. So you're going to run it at 2, you could run a stacked TSF. And I'll show some pictures later on about you have another ring here with 6 struts. Then you're going to run 2 separate programs.
You change the reference ring.
Yeah. So I'll talk about it. What I do, if I have a stacked TSF, I use, so you understand, so I have 6 struts up, 6, I have this frame, that frame. I use the middle ring as my reference ring for both frames. That means I have to get one X-ray on this middle ring. So this ring, this frame will be distal referencing. This frame will be proximal reference. But with the beacon, that you got to go one and one learner, you got to get twice as many X-rays. So that may be the many advantages of the beacon. But if you're running stacked frame, you've got to have separate X-rays, running separate. So I would choose my middle ring as my reference ring for both frames. It's just easier to get one X-ray center on that ring, and I can make the calculation, but it doesn't work for the beacon. You have to have one above the more X-rays.
It is not a standard to do between, so even in the afternoon will be the standard, it's only.
Yeah. And it's unusual.
It's
And
difficult.
later I'll show some examples of why you might want to do a stack TSF.
Okay, any further questions? I think we have the coffee break now. Yes, yeah. I think this is the time for coffee break. So we have 20 minutes. Coffee. And we'll back you.
أفصل الريكوردينج طيب أحسن خليهم يحضروا الفيديو ولا يمكن شو نعمل نوقف الكاميرا في اوبشن اعطيني اوبشن هذا يسمى زي خلص خلاص لا بس شغال هذا اللايف ستريم اعطيني بس ستوب مش معطيني بعد اعطيني مثلا